pleased to do that. And all the details can be found about our board meetings on our website. So, let me run through the agenda in the normal way, but first let me have some welcomes. So particularly Simon, Dr. Simon Stockhill, we're very pleased to welcome you to our board. Simon leads our primary care collaborative, and we're very keen to strengthen the voice of primary care at board. So on that basis, Simon, we welcome you, but we also know that you have a wide background and experience that you're bringing to this board, so we very much appreciate that. More emphasis in the year ahead and more voice for our collaborative leads, and Stephen will talk more about that when the time comes. We've also got a hello to Jonathan, who doesn't feel really much like a stranger to this board. Although you've only been in our system 6 or 8 months, we do feel very familiar with you, and we're very, very pleased to welcome you to the board.
In a good way, I'm hoping.
In a really good way, Jonathan. A really good way. And by the same token that Simon is representing primary care, Jonathan is going to be representing acute care and is replacing Simon Morritt. Here's my friend. And Andrew has been renominated as the collaborative lead for community services. So this emphasis around the collaboratives is hugely important for the board. We want to say a really big thank you to Simon Morritt, who's been with this board from its inception and has helped us develop the board. So it's important that we minute and note that. And there's another change around the collaboratives. Michelle, like Simon, has been with us from the very, very beginning of the ICB and has been a huge support to the board and also to me personally. So we've been hugely grateful for Michelle's contribution. However, in the scheme of things, it's been decided that Brent, the Chief Executive of TUV, who is the leader of the Mental Health Collaborative, will attend board, which frees Michelle from this this responsibility. So, Michelle, thank you again very much indeed for your contribution. And just so you don't feel left out, Jason, our 5th collaborative lead is Jason Stamp. So really, really important that we recognise this shift at board to focus around the collaboratives who work across our system. It's a change in the way that we're working, and I think it will bring a change of dynamic to the board. So important news. Now, Stephen, have I forgotten anything?
Chair, no, I don't think so. If I could just add a couple of sentences to what you've said, reinforcing really what you've said, that this is a really important change in the way that we're moving forward our ICB and ICS in terms of how we operate. So it's really firming up the link between the agendas for the collaboratives, to whom we are going to be devolving much more responsibility and accountability in this next 12 months against all the major challenges that we talk about regularly in this board. So it secures, I think, a much closer integration and working relationship with those collaboratives, and not to forget to place Amanda's here in effect with part of her remit, carrying the brief for all of our 6 places who are also part of that operating model. So that's the reason why we've taken this step of effectively fusing the members of the board with the leadership role for the collaboratives, and each of our colleagues have dedicated a notional 1.5 days a week to that system responsibility in this context. Thanks.
Yeah, thanks, Stephen. Just before we get into the meat of the agenda, let me just explain to the board the timings for today. So this public board meeting is 9:30 to 11:30. We'll have a little break then, and then we'll go into our private board meeting, which is 11:45 to 1:30. And then at 2 o'clock, we'll go into our board development session, which we hope will be complete by 3:30. So that's the order of the day. You can think about your comfort and also your eating requirements during the course of those breaks and manage them accordingly. So, item 2, are there any declarations of interest about which we should be aware as a board? Item 3, as I say, we're a full house, so we've no apologies. And item 4 takes us to the minutes of our previous board meeting. I am going to turn the pages on this. So first of all, for accuracy, page 2, welcome and introductions and moving on through. So page 2, page 3, and I do have something there, which I don't know if it's coming up later on the agenda, but I'm interested in the update on the Tuve court case. Teresa, is that coming up later in the agenda, or do you need to speak on it now?
I can do it now.
Please, yeah. Teresa,
okay.
Thank you.
So, just for to make sure everybody's up to speed, there were a series of suicides in children and young people services at Tuve, and CQC, following their inspection and consideration of this, decided that there were 3 cases that they wanted to prosecute the organisation for, and the prosecution was in the light of failing to provide safe care and treatment resulting in avoidable harm. Tuve pleaded guilty in relation to 2 cases and pleaded not guilty in relation to a 3rd case. And the hearing took place on the 11th of March in respect of the 3rd case that the organisation had pled not guilty, which was upheld, and they were not found not guilty in respect of that 3rd case. I think it's fair to say that the organisation had already identified that there were significant failings in the care and management of that young person, but the judge didn't feel that it met the same threshold of failing to provide safe care and therefore resulted in avoidable harm. There is sentencing expected on the 19th of April in respect of the 2 cases that the organisation pled guilty to.
Thank you, Teresa. Okay, thanks for that update. So moving on through the minutes, the remainder of page 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. And just to ask, that was for accuracy, are there any matters arising from these minutes that anyone's noted, or things that don't appear later in the agenda? No. Okay, let's move on. Thank you all very much indeed. We've got our own list of matters arising. There are 5 matters, but none of those are due to be reported back on till May, so I'm not going to touch on those unless somebody's got something they want to contribute around that. No. Are there any matters of any other business? I haven't been informed of any, but you may have something you want to raise at the end of the meeting. No matters of any other business. That takes us then to item 7. Item 7 is the board assurance framework. Just to remind those who are watching and to remind us, all NHS boards run a board assurance framework. It's a register of the risks the boards see that give the greatest jeopardy to the achievement of the organisation's purposes and ambitions. So we seek to keep an up-to-date record of those things that we perceive to be of the greatest risk to us achieving our organisational targets. It belongs to the board, and it's important that the board are across this board assurance framework and pay great attention to the mitigations. The risks in themselves may not change enormously, but the mitigations do. And that's what affects how we see these risks in terms of what it is the board wants to achieve. I'm going to hand to Karina, who's provided us with this paper around the board assurance framework, and ask you to talk through the changes this month.
Yeah, thank you, Chair. People will have noted that we've also added to this particular report. So you have the usual board assurance framework report, which is provided in the supplementary information, but in addition, we've taken the opportunity to review, as you would in terms of good governance, where we've moved throughout the year and how our year-end analysis and risk movement looks for 23-24, which is set out also in the report. Key areas for consideration are set out in section 3 of the report, but I will just go through some of those for you. So in terms of the board assurance risk A1, failure to recognise, monitor and mitigate actions to improve standards in local care for patient safety. This risk score has remained high over the past 12 months with low risk appetite. The board is asked to consider whether a deep dive of this risk should be undertaken by the board to get into a bit more detail around that one. Risk A3, which is a failure to operate with the ICB's resources and within the resources for 23-24. Obviously this relates to 23-24 and will be closed after the year-end work is finalised in June. A new risk is in development for 24-25 and will be fully populated once planning is complete. So that will be represented to the board in May. Then in terms of moving on, we have the immediate financial challenge, pressure in risk A4 and employment relation challenges, increasing workload, lead to level of reductions in the availability of workforce. Again, this risk has remained high over the past 12 months and the board is asked to consider whether we want to do a bit more of a deep dive into that at a future session. And the same with A6, which is the ICB's operating plan for 23-24. The board is asked to consider whether that should be a deep dive or whether we should open up a new risk for 24-25. And then I think the other key thing that we just wanted to raise is on item B2, failure to connect and build relationships with partners and stakeholders. We're making a recommendation to reduce the risk score from 12 to 8. This risk score has been approved previously, but we're below the risk appetite of 12. But we want to make sure that the board approve these changes and consider this risk potentially being closed and becoming part of business as usual. I think that's a quick run through there, Chair.
Thanks, Karina. Do you want to run through those asks of the board so we can answer your questions as we go along?
So in which case we will start back with A1. So A1 is the one about quality and patient safety, and the request was to whether we wish to do a deep dive in relation to that risk at a future session. We would normally do those in the development sessions.
Is there a view on that, Teresa?
Well, I think if I could just recap. So I think if the board can call, in year we've amended the wording in relation to this risk in recognition of the fact that obviously driving performance improvement to deliver improved quality and safety takes a period of time. It's not going to happen overnight. And our wording wasn't really reflective of that. Once we amended that wording, we were able to reduce the overall score in year, and that's you can see that under Appendix B, the reduction in scoring. However, the other things to say are obviously we discuss it every quality committee meeting in depth. We also, of course, have the system quality group where we obviously identify all the key risks to quality and safety across the system and actually identify whether there are any gaps in actions to actually mitigate some of those. On saying all of that, however, there are very, very clear risks to quality and safety that they are just inherent at the moment across a range of services, and we need to recognise that. So You know, there's no guarantee. We can do a deep dive. I'm more than happy to do a deep dive. And what I would suggest is if we are going to do a deep dive as part of the board, that actually we tie it into the outcomes of the planning round and the drive around some of the efficiencies we've got to make, and genuinely consider some of the quality impact assessments as part of that. So I'm more than happy for that to happen. I just don't think that we should ever build up the expectation that we're going to significantly reduce this risk scoring.
Okay, thank you. Any comments around that for Teresa? Well, I'm pleased you support that, and I think then we should. Having said that, I take assurance from the work of the Quality Committee. I feel it's a good committee, a strong committee, and I think we get really positive feedback from there. I'm also assured that you escalate to us things that you think the board needs to know and understand. But we can build that into our development sessions, and we will. So thank you, Teresa. Karina.
So the next risk is in relation to the financial resources for 23-24. As I've already said, we're in development is the new risk for 24-25. So I think we've taken a standard approach to that over the last 2 years. So I think I would just advocate that we recommend that continues, and we make that change as we go through, and we'll close the risk at the appropriate point once the year-end finances are closed.
Yes, I'm happy with that. Any comments? That's fine.
Sorry, Richard.
Oh, sorry, Richard.
Yeah, I think just to make the point in kind of opening up the new one for the new financial year, I think certainly at the Finance and Performance Committee it'd be worth looking at the new sources of assurance and the new controls, because I think there'll be new ways of kind of mitigating and managing that risk next year. So as each of the committees has a BAF strategic risk or some allocated against it, I think there's a little bit more detailed work to be done at all the committees in terms of the year ahead, in terms of source of assurance and the control system around those risks.
Okay, Stephen.
Could I just elaborate on what Richard's saying, because it's an opportunity to do so, that plan for the year going forward, we're talking about signing off last year. There's a process that doesn't conclude until the 4th of May. However, we're not waiting for that. We're acting on that already. The point I want to make in relation to this issue we're discussing here is a very high-risk plan, comparatively, purposely so, but a very high-risk plan compared to other ICBs across the country. So to make that point, so I'm reinforcing what you're saying really by highlighting that.
Thank you, Stephen. Karina.
So the next risk is A4, which is in relation to employment relation challenges, increasing workload, leading to reductions in the availability of workforce across the system. Again, this was a recommendation that we consider this for a deep dive as a board. I think there is a connection to the previous conversations about where we are with our planning and what that might mean. But Jane might want to comment.
Yeah, I will. Yeah, thank you. My points are probably similar to Teresa's, really. We've got the subcommittee of the board, which is the workforce board, that does the detail. We're just developing our Year 3 programme. You'll be seeing that slightly later on today. I welcome a deep dive on workforce at any opportunity. I think I've said that before. So similar point of view, but the assurance levels of it are done in that workforce board, and we do bring this to the board on a regular basis.
Thanks, Jane. Yes, Louise.
Yeah, thanks. I would support that, Jane. I'm just thinking about whether this is a risk that is with the ICS as much as the ICB, if it's about system and care workers as much as it is about health NHS workers. So we just need to be clear on the scope, don't we, whether this is a BAF board response or whether it's a system issue.
Stephen.
Could I just elaborate on that too? I think it's a really important point to raise, because each of our component parts, i.e. the organisations that make up the ICS, will have their own risk assessments and their own BAFs. However, this board is the convener, the coordinator for all of that. So I think it's important to note the fact all the things we're talking about, including the high risk structure I referred to, is a system risk just as much as it's an ICB risk. Thank you.
Thank you. So I wonder if maybe we should leave something to the half year or so, Jane, for this, maybe October time.
Yeah.
Because again, initiatives do take time, don't they? So a bit of traction, but maybe we could have a deeper dive, perhaps on something that feels pertinent to us at that point in the year. So we'll just make a note of that, Jane. Thank you. Karina.
The next one's item A6, which is the ICB operating plan for 23-24 and specifically associated with the delivery of the 31 national objectives. Again, the board was asked to consider a deep dive in relation to this risk, but given that it's a 23-24 position, we will be opening a new risk for 24-25. We've had a lot of performance reporting through the year. There'll be the annual report and the end of year alongside the financial position that will obviously lead to us closing this risk. We won't close it today, but when we've got to that position and we understand the final position, I don't know whether Amanda wants to add anything further as well to that one.
Thanks, Karina.
Yeah, thanks.
Amanda.
Thanks, Karina. So I agree with that, actually, and I think this board's got, particularly over the last 3 months, had quite a lot of detail on the operational performance objectives, particularly given the reset around the half-2 plan. We won't know the final outcome for another few weeks. We do know some of the indicators we have achieved and some we haven't, and some we're further away from. And that will inform our position going into the 24-25 plan and our achievement potentially with the objectives that are set, some of which have changed. I think it might be worth the board considering when we sign off our final plan for 24-25 some of the risks around that to the objective delivery, because there will be some, and then think about whether there's a particular deep dive we want to have a look at in relation to that risk.
Okay, that sounds helpful. Any further comments around that? So let's note that that's what we think we'll do, Karina.
Yeah.
Is that your list? You've got one more question, I think.
There's just, it's relating to 2 risks. There's B2, which is the failure to connect, build relationships with partners and stakeholders around meeting our wider population needs, and leads to fragmentation and reducing the impact on wider determinants that affects the population. We've said that that's maintained quite a low risk score throughout the year. I think we've received quite a lot of updates here in relation to where we are heading with our partnership relationships. We've talked about the new collaboratives on the board today being strengthened, and I think we're suggesting that risk is now closed off the BAF. It'll still be monitored through Corporate Risk Register, but that one will be closed. The same with robust governance processes and effective control mechanisms, and meeting our regulatory and compliance standards. We're recommending again that now doesn't need to sit on the board assurance framework, but would continue to be monitored through corporate risks.
Thank you. Any comments about that from anybody? My only reservation is it a bit like tempting fate? That would be my worry, but that's not very scientific, is it?
Chair, if I may say, I think the answer to that concern is that if we believe the governance system's robust, then it will come back. If it falls into this category.
Okay. I've got Peter, then Jonathan, then Charlie.
Thank you, Chair. Just in support of removing this from the BAF, I think the recent ICS meetings have demonstrated that the partnerships are very strong, and there was universal support for the direction that we laid out at the last ICP meeting. So I think we can take some comfort in the proposal.
Thank you. Jonathan.
It's just a reflection. I mean, I fully agree with it. Does it send the right message out when we're talking about inequality as wider determinants that suddenly we're dropping it off our risk registers? It's sending the right message. Probably is internally to ourselves, but I mean just the general public and other people out there.
Okay.
Any comment?
Then Charlie, then Anya, please, and then Louise.
I wanted to raise a separate point, so sorry if I was on this one.
So on this topic, Anya?
Yeah, I agree completely, thanks Chair, with what colleagues have said. I guess it's just how we don't lose that we probably still do have more to do in terms of some of the wider relationships beyond the immediate ICP. i.e. with business community, probably with other education providers, some of our other partners, and it's just not to lose sight of that, I guess. And I agree, it doesn't necessarily need to be on the plan.
Those are wise words. Louise?
Yeah, I think because this is about relationships and partnerships and stakeholders, but the point about need is that that's a mitigation for us to all understand collectively need, which I think goes back to the work we've been trying to do to quantify those health inequalities and make sure we've got a collective understanding. Of course, the wider determinants are a way in which to address those inequalities that we may see through the needs and the data. So it's managing today and tomorrow, isn't it, in terms of need assessment.
Thank you, Louise. Charlie?
I wanted to make a comment about A7, new risk, financial risk 24/5, partly because it seems very Groundhog Day-ish. You know, we're just finishing off 23/4 and then we're going to do 24/5, and it sounds very reactive, and that may be really appropriate to a board assurance framework as we go through the year. But I'm also conscious of the words that Stephen used in a recent meeting, which is about moving beyond deficit culture. And thinking, with that, I think, Stephen, you were suggesting thinking in a more strategic, medium-term way. And we are going to have an election this year, and unless all the opinion polls are wrong, it's probably reasonably clear how that's going to turn out. And there may be a dual rationale, A, of breaking out of some of the short-term reactive financial discussions, and B, in thinking about how working under a different government might be, to find space, perhaps not in the Board of Assurance framework, but to find space to think about the medium-term financial planning for the system, rather than reacting to the day-to-day pressures that we hear about at every meeting.
I think those are wise words, Charlie. Thank you for that.
Yeah, thank you, Chair. I completely agree with Charlie and also some of the comments that colleagues have made. I wonder if there's an opportunity here for us to think about as we go through the board today. We've also got some conversation about risk appetite later on in our meetings, and we've also got some time out as a development for us to consider some of this. Maybe we need to align some of the the risks to the new objectives that Stephen's going to talk about in a few minutes.
Yeah,
as well.
helpful. Thank you. Peter?
Yeah, thanks, Chair. As an aside, just to follow up on Charlie's point, is all local authorities are being required to produce productivity and transformation plans at the moment. But as part of the production of those plans, they are also being asked to note what the policy barriers are for sustainability. So as we articulate the risk around the finances for 24/25 and thinking that longer term view that Charlie's just articulated, we should as a board start to think about what are the policy barriers that we would wish to see removed that we could advocate through the national structures.
Okay, thank you. Jane?
Yeah, just in response to Charlie, so I think we're all aware that we've already commissioned that piece of work, and we are working towards a medium-term plan. So we've got the high-impact tennis changes, the system have agreed. That's the whole system, including local authorities. And sort of like the governing vehicle for that is the leadership forum that involves local authorities, chief execs of providers, place directors, and the ICB executive. So we are on with that. What that work then needs to progress into is a medium-term financial plan. But clearly, that's got to be underpinned by some more strategic work in terms of it's not just the finances, it's the strategy itself. And the plan that Stephen talked about in terms of 24/25 is a very challenging plan nationally, and we're still working on that, and the plan submission on the 2nd of May will probably be extended. So there's an immediacy and about what we do about resources and how we do try get to a balanced position, whether we can or not. But then the medium term, we've already commissioned that piece of it, and I think we've brought that to the board already, haven't we, in decisions. And then, like I said, I think then in the spring, once we've submitted the plan, is what does the medium term financial plan look like?
Stephen?
So just nail the action in that conversation, I think, and just to play it back. I agree with what Karina's saying. There's a couple of stages yet around, particularly the time out that we're having, where we can explore this in a bit more detail. This strategic context it's finance, it's quality, it's workforce, and it's critically our overarching aim around improving the well-being and quality of people's lives who live in Humber and North Yorkshire. I'll say a bit more about that when I get to the objectives, but I think it's a really good challenge for us to take away now, go through those processes and reflect that back in the bath. I think that was the specific that you. So if I could just try and nail that action from.
It's really important, and it sets a really clear marker, doesn't it, that our language around our financial position is changing, and the way we think about it and the way we talk about it is different. So thank you for that. That's hugely helpful. We're going to move now directly to Stephen's update. This is always a verbal update, as you know. And I'm going to hand over to you now, Stephen.
Thank you. There are two identified items on the agenda, which I'll get to in a second. And I've got, for the first one, you just touched on, Chair, there's 2 or 3 slides for the objectives that will go behind me, I think, all being well, in a moment. And then one of the very important objectives within all of that for the forthcoming year, the second item here, about our collective responsibility and specific individual responsibilities for equality, diversity, inclusion. Now, Anya's going to talk us through all of that, but just to make the point that individual executives, including myself, are carrying that objective very firmly into the new year that has now started. A couple of points of news, really, I suppose. I suppose it's important to acknowledge that the consultants have agreed a pay deal, but the junior doctors haven't. I don't know whether either Jane or Amanda have got further update on that position, but it sounded to me like there may be continuing junior doctor industrial action right through to the election. But I don't know if anybody wants. Anybody got any more information about that? Is that broadly it?
That's what we understand, although there's no dates confirmed as yet. But if there are, or when there are, we'll swing into action as a system in terms of what we need to do.
The second important bit of news, I think, partly linked to that conversation just now, and when we were talking about partnership working and the sort of operating model of the ICB and the ICS. You'll remember, because we had a presentation here, I think some time ago now, that the CQC are moving into assessing and inspecting systems. That was suspended earlier this week following a pilot down in Devon. The headline was ministers weren't comfortable with the outcomes. Now, don't ask me to explain what that means, but there's obviously further discussion to be had. So for the time being, those inspections are not going to happen, however they were scheduled. If I was speculating, I'm not sure we'll see any more about that until the other side of a general election, but we'll wait and see. So I just want to report those two things in. So if we could just, Mike, fling up these slides. I'm not going to go through them. There's a bit of detail on them. We can share them subsequently. Just to preface what I'm going to say about them in a second. Because these are aimed at 24-25, but I just want to come back to the sort of fundamental purpose of the ICB and therefore the ICS in our sort of stated strategy, our intentions for the last 3 or 4 years. And the most recent document that's been published about that is about improving the health and well-being and the quality of people's lives and reducing mortality rates in 2 stages, 2030, 2035. Now, they are long-term aims that we're trying to move towards, so we're trying to shift that dial. So everything I talk about I want to make it clear, is sitting in that context. The second thing is that we did have a bit of discussion here about the work that's gone on within the ICB, not the wider system, around the Barrett values that Jane has brought to us. Now, we're in the final process of firming those up. And, it's only sort of 3 words, really, but it's what sits, I suppose, the intentions that sit behind those words. I mean, yesterday we were out with all of the leadership of the ICB, working that through amongst other things. But just to remind you, those 3 things are: we are ambitious to deliver that overarching aim, amongst other things. We are innovative and we are transformative. I mean, I remember when we had our very first meeting, Chair, of this board in its early iteration, that we said we wanted to be a transformative board. So I guess it's reinforcing that message. I just want to get those things across, that's what we're trying to, and I know my colleague leaders who are here from the wider system are carrying the same words, but carrying similar messages. Now, all of this is really important because, in my experience, the year and the years ahead, actually, that we're going into are the most challenging that I can remember. And if I talk to any of my colleagues and up and down the country, that's what everybody says, and it is. It's really and that's not just about the financial challenges, which we'll hear about it's about the whole range of challenges. It was only in the last few days that, again, there was national coverage about the reputation of the NHS in the context of what the general public feel about the NHS. And I guess we'll see all of that ebb and flow as we go through this process of leading to a new government. So I just wanted to get those points across before I then say, well, then we've done quite a lot of work within the ICB. So these are ICB strategic objectives. Colleagues have been with us for a while will recall we've done this every year at the beginning of the year, so hence these objectives are here for any discussion we might wish to have, but they're here for sign-off because they inform the wider system. In particular, these then translate into specific objectives for myself and for the executive directors and for the workforce that makes up the ICB. So they're really important in that context. We've really tried to keep them very simple. There's only 3. Now that's in the light of the NHS framework for last year had, I think, broke down into 31 aims and objectives for a year. But actually, when you broke that down further, you were still looking at something like 130 specific things that needed to be done. So, so it's all within that framework. But what we're trying to do here is not only recognise what the NHS requires, but to recognise what this board is about, which is a much more collective partnership. So there are 3. So I don't know if we've got them behind me now. So, so the first one is leading for excellence. I'm not going to go through each of these points on here, but I mean we would know, Chair, and other colleagues will, from many of the things we do about going around the territory. There's huge examples of excellence, excellent people, excellent activities, excellent services, but they're not consistent. And one of the big challenges for an ICS and ICB is how do you get scale change around excellence? So that's one thing I want to emphasise. The second thing is, in my experience at least, you only get to excellence through excellent leadership. So that's very much a big part of what this objective is all about. And you only get to achieving our aims through excellent relationships and partnerships, etc., which we've heard a bit about being in a good place for us to build on. So I'm not going to go through all of those, but so number 1, leading for excellence. Number 2, got it in the right sequence, Andrew, leading for prevention. Now that really is sort of trying to capture in the next year how we're moving towards that overarching aim, what we're going to try and do there. And I think we sort of collectively recognise that the system that we're operating in at the moment isn't working for the people that we serve in many ways. And if you look at all of the commentary, even the commentary in current government and in potential future government, it's all about this shift. And indeed, when we see the film, if we see it, so I would sort of steal its thunder. That's what that film's all about, which is it's worth seeing if we can. So this is really trying to emphasise this is the fundamental change that we're trying to make. In the light of recognising that if you've got somebody who's waiting on a waiting list for 2.5 years with needing a knee operation, who isn't mobile, that has to happen as well. It's both of those things. And then the third one is leading for sustainability, because the logic of what I've just said is that the way that we're currently organised, and that is true in the way with some of our services that are fragmented or not necessarily meeting the standards we would like to see. How do we get to a position where those services are sustainable? And just to make a general point, which is not just about the ICB are convening this, but it's about the system as a whole. We're doing a piece of work, colleagues will be aware of this together, which should have an output by July, which is looking at the way our services are organised with a view to what should they look like in 3 to 5 years from now, and how do we within that achieve sustainability. The other thing I would, two other things I would add to that is this is where I think a lot of the quality agenda falls in, because we have got some very significant quality challenges. There's a very good example which Jonathan Lofthouse can talk about better than I can around stroke services, that if we were to able to make that change, we would see a significant improvement in quality of stroke services across our system. And other examples like that. And then the other thing I'd emphasise, of course, is workforce in this context. So there are lots of challenges around workforce sustainability as well. The last one to emphasise, we've touched on a bit earlier in the meeting, is this putting the patient or the community voice right at the heart of what we're trying to do. Now, that is not really a new aim, but I would argue in the context of the challenges that we've been touching on, it becomes even more important, bearing in mind that I think we're going to need to have conversations with our communities about some of the difficult choices that we might have to make with the limited resources that we have, against what we determine in each of our places are priorities. And I don't think there should be any doubt around this table that when we talk about this being one of the most challenging years, that's part of what we'll be getting into as we finalise our plans. So I didn't really want to say any more than that, other than just give a brief overview and ask the board to by all means comment or discuss any elements, but more specifically to approve these objectives for 24-25. Thank you.
Are there any comments for Stephen? Anything anyone would like to add? Jonathan?
Chair, thank you. So I'm really happy with the objectives, but the first leadership objective and Chair's viewpoint about the vortex of acute, I think the language around the acute financing, it might be a little bit brutal for the audience. So I take the sentiment, but I think we might want to maximise where it brings the best good to the patient, whether that's in health or social care, rather than an explicit we want to shift cash out of acute. I think it's a little bit too overt for comfort, although I don't mind moving money where it better meets the patient's need.
We can act on that subsequently.
Okay, Jane.
As well, the 4.2% is the when was the first plan submission? It's touching nearly 6.5% the efficiency ask. So we probably we might just need to couch. We might not put specific percentages. It might be about efficiency to enable us to move to a more financially sustainable place or something like that. Do you know what I mean?
Okay.
I think putting a specific percentage probably isn't helpful. I don't think.
Okay. Simon?
Just to balance Jonathan's concern about the language, I think it said resources rather than finances, and I think that's the key. It might not necessarily be about taking cash from one sector to another, but using the resources, which, let's face it, the bulk of our resources financial, with then some element of estate and then some element of expertise, and using that differently. And that is often easier than decommissioning a service, releasing cash and then buying it from somewhere else, but is actually to properly integrate services so that resource that previously sat in one sector doing something different is being deployed differently in an integrated way, and therefore out of a single sector and across multiple sectors. And that's what we should do, which is why I think it said resource, not cash.
I'm happy with that. So I'll go with that.
Thank you. Any other contributions to support Stephen with this?
No, but that's very helpful, and I think we can take those sentiments away and reflect them. I think on Jane's point about percentages, I think that's an interesting point. And again, there may be another way of phrasing that, but I think it's worth making the point that our efficiency requirement requires us to save, and we're already on day 10 of the new year, £7,200 an hour to move towards our current financial efficiency requirements, and that may change further, as you suggest. So just to make that point, or £1.2 million a week, if you want, and that's just the ICB. So just to be clear, I think numbers are important in that context. Thank you. Okay, thank you. Do you want to move on, Stephen? Well, and that concludes my part of this item. I'm going to hand over to Anya for equality, diversity and inclusion. Thank you.
Thank you, Stephen. Thank you, Chair. This just follows recent conversations at board, and particularly where we approved at the last board meeting our EDS submission. You will recall with the rating of developing. So some immediate objectives have been developed, encapsulating the key themes from that EDS work, which are in the paper within the pack. I won't go through the detail, but you can see there that there are 6 objectives picking up on those key themes and threads. These objectives will continue to be developed further over the year as we progress the work around our EDI ambitions, and as Stephen said, it isn't captured in here because it was an action agreed at one of our previous board meetings, but that is not only that each board member will have specific EDI objectives, but actually that all ICB staff will also have specific EDI objectives. So these are just to note and to take any questions. Thank you, Chair.
Thank you. Any questions for Anya? Just to say, our EDI training is when you'll have read your papers, is coming up, so you know about that. And also, you will also have read in your papers our commitment to, and thanks to you all for your thoughts about how we might improve our diversity at board. That was really helpful, and we'll talk about that later. So thank you very much indeed, Anya. That's definitely something I think we would like to hear more about 6 months in or something. Okay, let's move on to item 9. Item 9 is the performance report. This is reporting on month 11, Amanda. I don't know if you've got some upfront information about where we actually landed at the end of March on some of our higher level metrics. Over to you.
Thank you. And we had quite a detailed discussion last time around the challenge with this being retrospective and the information being out of date, and also the complexity of the associated dashboard and actually pulling out the key nuggets of this. So for this month, and as we move into next month, this report will be iterated to make it more user-friendly. I don't intend to go through the detail in here because for a lot of people it's not terribly accessible, and we've tried to create a narrative headline report that pulls out where we are against the plan, and then a summary of the performance, but more importantly I think the key actions that across the system the different bits of our constituent parts are taking in terms of recovering that. And as you say, this data in the pack is January and February, and I can indicate where I think we might end the year, bearing in mind we haven't had all of the completed returns yet. So just a couple of things, if I may pull out, just in terms of urgent care. We've obviously seen a challenge in relation to urgent care performance as we have moved through the year. What I'll do is I go through these, I'll pick up where I think we might end the year, if that's helpful.
Fine, that's good, Amanda.
Jump about. And obviously when we went through the H2 plan, we reset that target, but we're still with an ambition to reach the 76%. We have had a number of challenges related to some of the industrial action, but also demand and workforce challenges and flow. In terms of the final endpoint, all of our trusts tried really hard to reach the target that they'd set, and there was a variation. So Harrogate had a more ambitious target than the 76%, and the other trusts were at around about 76. We think we will end the year at 70%, which, given the challenges that we've had, we actually do think is a significant achievement, and reflects the effort from all the staff in the ED departments and the hospitals, and also colleagues in the ambulance service. We're just validating that data. There is an awful lot of learning that has come out of the last 6 months that we are reflecting back into the plans for this year. The other aspect of urgent care that we look at closely is the category 2 response times. So we have seen an increase in the performance across both, particularly in YAS, but neither YAS nor EMAS met the 30 minutes targets. And there is a discrepancy in the YAS targets between North Yorkshire and York and Hull and East Riding Patch. North Yorkshire and York does better. I'll not go through the actions in terms of what we're doing, but just to reference the MAID events, so the end of March coincided with Easter weekend, but we did have a real focus in terms of MAID events, looks at all of the opportunities to...
Just remind us what MAID stands for, Amanda.
Oh, I can't remember.
Anyone got it on the tip of their tongue?
Multi-agency
discharge evaluation.
Got that?
So it's basically looking...
Intensive focus
Yeah.
on discharge.
Yeah, it's
What do you
basically
mean?
looking at all of the opportunities for all of our patients in the emergency department, particularly interface, to stop the clock and move them on to either being discharged, admitted, or another alternative. It's the multi-agency aspect. Okay, just in terms of planned care, again, planned care, if we go back to where we were at H2, a significant challenge to end the year, a huge amount of work across the trust, particularly across our trusts working together through the collaboration of acute providers, particularly looking at how to maximise the capacity that we've got to address the waiting list. And whilst the waiting list size did increase over the last few months, we have addressed the backlog in terms of the waiting list position. So in terms of the elective performance, we have ended the year with 8 78-week breaches, which are complex cases. But in terms of the 65, we have exceeded our target, which was 350. So we have over-delivered on the plan for that. We still have a lot of challenge in diagnostics, and we have a challenge going into next year with diagnostics. There's a particular amount of work on that. And just in terms of cancer, just to pick up that again, we have done exceedingly well in terms of where we've ended the year with cancer. So in terms of the end of the year position on the 63-day cancer, we're ahead of our plan there as well.
Shall we just pause there and see if there are any comments anyone wants to make about this performance analysis of our acute system?
I was going to say that's the acute bit. There's 2 bits to come into.
Jonathan, do you want to add anything?
I think we have had that real gear shift since the H2 plan reset piece, and I think the 3 acutes and Amanda, who's kind of held the executive burden for UEC, have actually really been quite tight on that. And I think actually where you look at our longest waiting patients and you look at the impact that we have had on cancer in a positive nature, it really starts to amplify far more mutual partnership across the totality of our resource system. So, you know, we talk about our 100 NHS operating theatres, we don't talk about Hull's operating theatres or Harrogate's operating theatres, as an example. I think the issue for me moving into the new operating year is the diagnostic piece. If we hit the diagnostic piece hard, and clearly we've got major investments coming online later in the year in terms of the CDCs, will unlock the additional acceleration in the cancer pathway. That's where the delay is. That's the constraining factor for the cancer delivery piece. It's the hard-hitting diagnostics at the early end of the pathway. So we'll have a dual impact for our patients if we can land our CDC schemes and land them well.
Okay, thank you. Amanda, onwards, mental health.
Yeah, okay, so we did have quite a discussion last time around mental health in terms of the fact that we are not delivering where we want to on behalf of our population against the 9 mental health indicators, and also that there was a discrepancy in some of the local and national data. We have done a deep dive into that and have pulled out where we are. So 2 of the indicators we do meet, and this is pulled out in the paper. I'm happy to take any questions in terms of the detail. So the access to children and young people services and the annual health checks for people in our community with learning disability, the health checks element, which we know that people with a learning disability and or autism are more at risk of long-term conditions. So this is about improving overall physical health for those that have got a learning disability. So that actually is on track. In terms of the other 7, the access to community services, we're not where we want to be, but we had a very ambitious local target, but things are improving. And also in terms of some of the others, while we're not where we need to be, in terms of the talking therapies target, we are at 93% for planned target. That's often about people not coming forward for service. And in the dementia diagnosis rate, again, we've seen really positive progress. And we know that not everybody with dementia has a diagnosis. There's more work to do and is being planned to being done around access to perinatal services for mental health, for pregnant ladies who need access to perinatal mental health services. We're red on that indicator, and there's an improvement plan around that. And then just to pick up the active area placement, so these are people who, it's counted in bed days, so it's an inflated number, it's not people, it's bed days. But it's a poor experience for people being out of our area. And again, there's a big focus and plan linked into the transformation work around the wider mental health collaborative that's been picked up on that. So we're doing a lot of work to get a detailed understanding of actually where we are, and then put proper plans to recover the performance and improve that as we move forwards in light of the new operating framework guidance.
Thanks, Amanda. It couldn't have a higher profile in the media at the moment because of mental health and young people, for sure. Anyone else want to make any comments around mental health? First, Michelle, thank you, and then you, Charlie.
Yeah, no, thanks. I think it's a lot more reflective. I think some of the things we've been conversing about over the last couple of months, not just about the data collection, but actually how it links in. So, yes, we know we've got a lot of work to do, and we have started some plans. So I have been overseeing it specifically, the performance over the last couple of months, which obviously will go back into the collaborative. I do think that we continue need to do the deep dive, but just from an organisational point of view, one of the main issues was our Lorenzo system. We feel we've got a solution in relationship to that, so that will also help propagate the data for next time. But we do know we've got some work to do, and we're going to, I think the idea is that we were going to assign some big pieces of work to various chief execs to lead, and obviously performance will be one of them as well. We've already got the leads from the out of area placements. We've already done quite a bit of work on that. And I think we need to just have that transparency about what we're talking about in relationship to out of areas, because it's quite multifaceted. Is the out of area placement piece, but we do need to do some more specific work on particular areas of the plan, but I think it is more reflective of where we're at. So we've got a lot more work to do, which we've never said we haven't, but I think it is catching up, and I thank Amanda and her team as well for working with, obviously, some of the operational team as well.
Thank you, Charlie.
This is a reflection on what you might call an unrecognised element of partnership, and that's about the support that universities give around mental health. And I've got 2 perspectives on that. One was a conversation I had yesterday, very coincidentally, with a student support officer in one of our academic departments, who made the very, very valid point that universities are picking up where NHS support is absent. And there are 60,000 students in our region, roughly speaking, and as a proportion of the age group, they're largely in that 18 to 21 period. That must be a relatively significant period of that age group for the system as a whole. The second reflection is a very tragic case at the University of Bristol. You may have heard about this, a student's suicide, which was a consequence of extreme distress in an examination situation. Yet that student had not declared that effectively mental health disability through university processes, so it was unrecognised and unmitigated. Yet in the High Court, the university was found at fault for not mitigating an unrecorded mental health disability. And now that's pushing universities to think even harder, for obvious reasons, about mental health support, which our services are under increasing demand. So in effect, we have become healthcare providers. Yeah, I'm not sure this is recognised by the ICB or the ICP, because we have a partner in the delivery of healthcare, which we're not considering as part of our mental health process. It's a thought. Should we be?
Yeah. With that goes a number of educational establishments, doesn't it? Primary schools, secondary schools. It's across all education and business. Yes, you're right. So that is something we should note, and that is something we perhaps should talk about in the ICP. So thank you. Teresa's got a comment, as has Michelle.
Yeah, so actually I was going to say, to start with what you've just said, is that actually this is across lots of other environments, including primary schools, and obviously there's a lot of work on supporting mental health in education, and there's a lot more that needs to be done.
Yeah.
The caution I would add to the conversation for us to think about, however, of course, is not to conflate support with mental health with mental ill health, because they're fundamentally different.
Yeah.
And we need to be cognizant of that, because obviously that's how we need to look in terms of how we resource our services.
Yeah, thank you for that, Teresa. Michelle?
Yeah, really, I'm going to say exactly what Teresa said in many respects, that there is a real finite difference between that support, and it goes in, not just in universities, but in general education as well as actually mental health piece, and that labelling is really important. I know that providers, and one of the things that we have to do better in the collaborative, which I'm sure will happen, is share what happens across individual providers. For example, my organisation does provide a lot of support into educational services, be that primary education all the way through into universities, and that's for both a little bit of support in its wider sense and to build on the capacities that they've got, as well as actually some active therapeutic. But I also think it's about that communication with how students can access the other services that are available as well. So I think we need to maybe just sit down and have a conversation about that, and just say, because there is more that we can collectively do together about that issue.
Charlie, you're allowed to reply, and then I'm just going to ask, we've got 3 practising GPs in the room. I'm wondering if they've got a view. So you, Charlie, first.
Well, it's just a thought. I mean, we do provide a whole range of welfare support services in universities, which are largely about the prevention of mental ill health or the mitigation of more modest manifestations of it. But we do have clinically trained professionals who intervene to help deal with acute mental health conditions. So we are a provider in that sense. And so I do think, Michelle, that offer for a conversation about how that provision of mental health interventions in often really quite acute cases should be part of our partnership discussion in a much more explicit way.
And particularly as we can see what's happening with the trajectory.
Yep.
Simon?
Yeah, two points. I mean, the 2 biggest issues touching on this that I would say hit my consulting room. One is the lack of integration between health and education with regard to young people, neurodiversity issues in particular, and how that then can also link to educational achievement, to behavioural issues, and to other, and potentially to mental ill health, not just supporting mental health. And then so there's definitely more we can do there, because often these young people and their families bounce between services without actually, and it's largely because nobody quite knows what to do and nobody's got the resource. So there's something about us putting our collective heads together to still keep challenging that. And the other bit relates to, I guess, in terms of mental health related sick notes, I write more for work-related stress than for any other single diagnosis. And so there is absolutely your point, Sue, about there being something about how we work with business, industry, with employers, and also with other sectors, such as Charlie's outlined, to ensure that there is that joined-up approach. Because very often, when I say to a patient, have you talked to your line manager about an occupational health referral, it's the very companies that don't immediately offer that run into the biggest sets of problems, and that is an obligation on employers to have occupational health services available as part of their employment duty. So there's something about how we work together and integrate those services so that they can work closely together where there's a patient who moves from that needing support for their mental health into true mental ill health. And I think that at the moment that barrier is not there. The barrier is there, the integration isn't.
What a useful conversation. You know, we often say, don't we, health is everybody's business. This is a conversation which tells us that, isn't it? If we thought that was a concept, we now know it's a reality. I'm going to go Stephen, and then I'm going to go Andrew, and then we're done.
Well, I was just going to, maybe you might want to go to Andrew first. I was just going to clarify what I think the action is from that conversation.
Okay.
No, that's fine, Stephen. Andrew Biddle. I was just going to say that it's really interesting, isn't it? Because we've actually got the resilience hub at the moment, which is really, I mean, it has done some remarkable things with getting people with mental health back into work. But also in supporting people and reducing, some quite good outcomes, really. But it is sort of like going to probably disappear, and I think that potentially is a concern, because I do think that for partners like Charlie and the ICP and others give that opportunity. There's a real opportunity there to actually link in but the trouble with it is it's funding. So actually you would be asking the universities to pay now, because it has to be self-sustaining, and others to pay. And I think that's a reality of the future, is that actually we cannot. We're sat here in lots of meetings, Steve, and talking about how much money we haven't got and how much money every minute we have to save. I think there's a major thing, and I think it comes back to that work that Anya was talking about, with having those conversations now with people, with industry and others, about how they have to come up to the plate as well to improve their pastoral care, because actually that's the thing that's missing, is the pastoral care and access. And if we can come up with a model that's good quality access to mental health support but also wider occupational health, then surely that is partly NHS fulfilling its role in terms of linking people and business into what it's doing. So how do you get some practical things from actually what is a worry? And I mean, Charlie's right. I mean, it doesn't just affect the university. It affects providers in health services. We can't get our staff who work in healthcare into mental health services, right? They're actually working with those mental health services in an integrated way. So actually, it's a stream of things that are going on, and where we're seeing sort of like this demand start to peak in other places. That I think is, for me, the discussion, Sue, not actually saying that the university is a special industry. I think it is. I think it's got a lot of students that are vulnerable, and we need to really work closely around what that meeting, what those outcomes, and how we can support universities better. But at the end of the day, everybody's feeling the same out there. So I think it's, if we got a message that we're looking at that with others, there'll be big industries saying, come on, we're struggling as well. We've got a lot of workforce off that can't get mental health support.
Yeah, thank you. Jane, a nice quick one, please.
Yeah, it is quick. I just wanted to reinforce what Andrew had said about the opportunities at the Resilience Hub and the impact that they've had, actually. And we've just written out to everybody to see if they're willing to continue the funding for that, and we'll come back to that, I think, in due course. But it is, they have done some great work, Andrew, you're right.
Good.
Thank you, Jane. Stephen, finally.
So I want to just summarise what I think the action is coming out of that, because that's a really important conversation. Before I do that, just a specific on the Resilience Hub, because I think what Andrew's talking about is the funding stream for that is not there anymore. And now there is an economic equation here, actually, is without going into the detail, which I think should be part of our future action, is, well, how much would you save, actually, if you kept it and you extended its capacity? But anyway, that's something I think we should do. My proposition, this is, for me, is the ICB in its sort of role as convener, coordinator, and in this context of centres of excellence. I'm not suggesting, but so it feels to me, and it might be for the company secretary to coordinate at least the initial discussion, that there should be some conversation, mental health collaborative, in the ICP, as was originally suggested by Charlie, and more broadly picking up that business point, because I think this is really one of the areas we need to be campaigning in and promoting. So, Anya, I think it's quite an important part of this for you and for your, your resource. I think there should be a piece of work done on that, and we don't necessarily agree the timescale here, but certainly within the next couple of months to get a view back then about what we might do, including just a quick evaluation of the mental health resilience hub, because it's also about would the mental health providers and other providers contribute to that just as much as universities and others. Let's not get into a debate about it now.
No, but we've been trying to drive the model, to support the model, by getting providers to agree to fund it, right? So at the moment it doesn't look viable because we haven't got enough. The point
I'm agreeing.
The economic model's done, Stephen. We've done the evaluation, so it's all done.
So I think there's a whole series of actions there that we could probably firm up and include in our action list with a conversation bearing time here outside the meeting, and it could reflect it next time with a view about timescale to come back.
Such a helpful and important conversation, and a conversation that we do need to have. So thank you all very much indeed for your contributions. Amanda, back to your report.
Excellent conversation, really helpful, and it's good that we've been able to clarify some of the detail on that. Just a couple of other things then, because I know I'm out of time. Just in terms of primary care and out of hospital, so we sometimes, I think, overlook what happens in primary care and in the out of acute hospital space, and there are more patient contacts with GPs and practices than in any other part of our system, and Humber and North Yorkshire will over-deliver their plan for additional general practice appointments, both GP appointments and non-GP other healthcare professional and practice staff appointments at the end of the year. And there's also another cohort where we commissioned some additional appointments through the extended access and also through winter monies, particularly where we put GP into the ambulance call centres. That's all been evaluated as well. And also just to say that we have committed and spent all of our additional roles money, which is about additional members of staff in the practice teams, and we hadn't done that previously, so we've managed to achieve that this year. And dental's not mentioned, but there's a focus on dental recovery. We now commission dental services. The measurement is in units of dental activity, which we're moving away from into commissioning sessions which are more accessible for dental providers and patients, often in terms of urgent access. So hopefully, again, we will continue to improve against that action. And the two elements of performance in terms of primary care, same day and then 14-day, again, we do really well, recognising that it's clinically appropriate for some patients to wait more than 14 days, and the data is being altered to allow us to record that. In terms of community services, there's been some change to the metrics as we move into next year's plan. A number of metrics being dropped, and also we recognise that there's not a lot of rich data from community services. There's now a data set that's come out nationally, a piece of work around recording community services data. It literally came out on Monday, so we're just working through what that means. But the waiting list, the community waiting list, has dropped, and so is nearly 7,000 under plan and has reduced month on month. A number of those will be people waiting appropriately for treatment, and equally there's a big chunk of that is community dental that we're working through. Okay. In terms of maternity, we've picked up pulled out the specific data around neonatal deaths and stillbirths. Just a big caveat that the numbers are tiny, so the percentages can be misrepresented, but we continue to indicate and work closely with quality teams. And then there was an ask about workforce. So we are going to do this in a bit more detail, and obviously links into the plan as we move forward into 24-25. So in terms of staff sickness and that aspect of levels of sickness, we're on track with that. Retention rates, we're not, and also we do know that we're not where we need to be in terms of agency spend particularly, and so the workforce is a big contributor to the overall financial challenge. We're continuing to iterate this, given the feedback that we've had. We plan to have a more accessible summary document that doesn't have all the level of detail but pulls out key things and themes that the board need to be aware of, and opportunities to deep dive where we think things are off track and we want to get underneath that.
Thank you, Amanda.
That's okay.
Thank you. Any comments about those concluding areas? Yes, Bushra.
Can I just ask a question? The community waiting list, what's the time frame on that? How long do you wait before you are on the community waiting list, and what's the longest wait on that list?
I can't.
And Andrew's pulling a face too. I don't think anyone can.
That question. I mean,
Off the top of my head.
The answer is we can find out for you though, Bushra.
That's a very detailed question.
It is a very detailed question. We could try and we'll find that out through Sean and that and let you know. So, but can I just say that some parts on that community dental are frightening. So, yeah. But also, and that shows where we've got the need and the focus around dental, which Amanda and others, now the ICS is leading. But I also would say that it's not really reflective, because say a district nurse, this has been part of the problem with the data, say a district nurse sees you, but we apply now like a super absorber onto your leg, so you don't need to go for a week and a half. That might be classed as a wait, but it's not actually waiting, it's actually part of the clinical process. It's yet again a blunt hammer to crack a nut. What really should be focusing on, what's the paediatric wait for specialist peds, what's the wait for dental, what's the wait for optometry, and what's the wait, well, specialist optometry in the community, and what are we waiting for in terms of sort of like some of them specifics around autism for kids and young people and some of the others. And I think they're the community waiting lists that we should be focusing on, because they are the ones that we will see detriment, some of them being altered by the centre thinking you can count visits, which are not, which shows a lack of slight understanding about what a community nurse does in some respects. So.
Yeah. Thank you,
That's
Stuart.
okay.
Yeah, it's a point forward really on the performance report. So I like the new summary. Given that we now have collaborative leaders represented on the board, I wonder if going forward we could take the views of the collaborative leads, perhaps just one or two of the areas that the performance report deals with each time, and have a specific requirement that we hear from, say, primary care or whatever it might be, as a sort of semi-deep dive into the performance report.
I'm sure it's been good to draw the collaborative leads in, I think, to the conversations we've gone along today, so we can talk about that later.
Yeah.
I do want to say, just before we close this agenda item, a huge amount of work goes into producing this performance report. I absolutely know that's from Amanda's team, and it's also from Karina's team. And I'm grumpy about the report. And I'm so grateful to you all for being patient with us about it. I'm not grumpy today. I think it's and I'm sure we can get better. So just you know, I've got something to say when I don't like something, but I think it's important that I say when I do. And I think all the board probably support me in that, in our one-to-one conversations. This is an area that we all want better transparency on. And actually, wasn't that a great conversation? So, such a good conversation that we're in trouble for time. On to item 10. Jane, this is you and your finance paper, please.
Okay, thank you. Thanks very much. You've got the paper. I'll just go through the summary document and pull out a few highlights. So this is the month 11 position, which is to the end of February. And there's some significant changes that happened as part of the reset. So there's some additional funding that was deployed into the system to cover industrial action, which was £8.4 million. And then in addition to that, all those systems that had reported deficit plans, there was national funding to match that deficit plan. This doesn't provide additional resource, it just means that we go back to a balanced plan, and that's what we've got to achieve. So it doesn't give you access to any more money. The other thing that is worth saying is that we will still be treated as though we had a deficit plan, and the two things that apply to us, one is ability to access some additional bonus capital is still at the same rate as if we had a deficit, and the other is that the £30 million deficit will have to be repaid, not in the next financial year, it's the following financial year, and it's maxed at maximum at 0.5% of the allocation, so we'll still be treated, but it's really welcome from providers because this provides access to cash of £30 million that they are in desperate need of, so I just thought that was worth clarifying. So in terms of the actual month 11 position, we actually had a deficit of £16 million against a planned deficit of £7.5 million, so it was overspent by £8.5 million. We had some efficiency slippage, which you can see in the report, of £18.1 million below plan. And also, it's just worth noting that the residual risk at month 11 was £2.6 million. I just thought it's just worth pointing out that at the moment we are firming up the final position for month 12 and year end, and I've had a meeting with all the finance directors on Monday. And although it's tight, we think we will get to a balanced plan for the full year. So I think it's just worth noting, and that will be brought back at the month 12 position. And I'd just like to say that the resources, when you look into the report, we've got £3.9 billion worth of resource spread across our providers and the ICB, and that is a significant achievement, and people work really hard and also in a mutual way to get every organisation to financial balance, which I think is a fantastic result compared to where we were several months ago. So I just think it's worthy of note. The other thing just to point out is the capital position. Although we are significantly underspent at month 11 by £38.4 million, we actually are going to forecast to be overspent by 11.4. 8.8 million of that is related to this IFRS 16. It's a bit of a technical thing around leases. And it's to do with the Whitby Hospital that I've actually talked about before, and that's allowable in the system, so we're just working through that. And then also on the core, what we call core CDEL, which is the capital allocation for the ICB, 2.6 million over. That is with permission of NHS England. So what they do at the moment is the systems will be up and down in capital, and what we're trying to do is get as much capital as we can spent and utilise people's underspends, and that's been facilitated. That's usually, and it isn't cash backed, so that means you don't get the cash to do it, you get the permission to spend it. So it's this what they call a CDEL limit change, and those things are moving around. And even of yesterday, we're getting movements still, so this is a fluid position. And I will update the board when we finish at month 12. So we've still got things moving round. That's the last bit that we're moving at the moment. And I just think in terms of the dashboard, which is on in the reds and the greens in the report, I think it's probably just worth saying that from an ICB perspective, we've underspent our establishment costs by just over £9 million. We had a plan to do that by £8 million. That was one of our efficiency programmes. So we slightly done better than plan, and I think that's to do with the controls that we've got. We've got the agency panel and that looks at both pay and non-pay, and I think that's a subject of those controls that we've put in place. We've managed to pull that back. And I think the other point that Amanda did briefly mention is the provider agency costs are overspent by forecasting just over £20 million, but a significant proportion of that is due to strikes, so that the whole position on agency has changed, and there is a new target in the plan of 3.2% of turnover for providers in the plan for 24-25, which if there aren't any strikes we might deliver, but we'll address that in the year. And that's all I wanted to say. And just one other point, sorry, you'll notice table 3 is still month 10 in the report, so apologies for that. That is absolutely my fault, so apologies that that table is, and what we'll do is I will amend the table so when the papers are put on the website is the right information. So apologies for that. That's one of the tables is still month 10 and not month 11.
Thanks, Jane. Comments for Jane? Anything anyone would like to raise with Jane? Jane, can I just double check that big finance report is going to all our trusts?
I've asked Laura to do that on a monthly basis. So
okay.
Yeah.
So we just check that it's going.
And they are publicly available as well, Sue, as well. Yeah.
Thank you, Jane. Let's move on then to item 11. This is the board committee summary reports. I think universally people appreciate these reports. I think universally they're helpful and they give us a view across the entirety of the work of our board. Remember, these committees act on our behalf. They do the work for us that we don't have time to do at the board, and they provide assurance to us, but they also provide us with matters of escalation. And you can see those being provided for us here in the report. So first of all, the Quality Committee. There are 4 alerts for the Quality Committee. Am I going to you, Mark, or to Teresa?
I think we'll start with me, Sue.
Go on, Mark, please.
Okay, so I won't go through these in detail unless people want to ask questions. There are four things there. We talk about a lot of things in the Quality Committee, but there were particular issues that we wanted to highlight. I think one of those I would like to just mention is about we had a presentation on population health, particularly looking at the way the age of our population moves over the coming, decade, to be honest, which did highlight some quite serious issues, if I understate it slightly, about the population that we're likely to be dealing with as we go forward, and the over 75 population and the health challenges that brings. And I think it landed with the committee in a way that it's maybe we've heard this before, but it landed very strongly. So I think to highlight that to the board as an issue we need to look at within the committee and within our our broader system as something that's going to be really, really important for us is something that we wanted to do.
And we've got two things around that, haven't we, coming up? One is we're going to have, I think, that same session at the board timeout. And the second is at our symposium, to which we're inviting all partners. The focus is around ageing. And you're right, I think we've spoken about it, I think only at the last board meeting, didn't we, say this, in our world there's a lot we can't predict. Here's something we absolutely can predict. And it is an unstoppable toboggan, isn't it? So absolutely right to raise that. Anything else, Mark?
No, I think I'm happy to take any questions, but that's the one I wanted to call out.
Thank you. Teresa?
Could I just add, on that point, the data goes back to previous years, predicting the position that we are in terms of some of our UEC demand and capacity requirements that, you know, in terms of capacity we don't have. So it's a really powerful presentation.
Thank you. There are three risks that come out of the Integrated Care Partnership. I think I can probably speak to those. The first is system risk in relation to the financial position. We have to remember, and we try to remember all the time, and that's where our no deficit culture motto has come from, that we work with partners who also face financial challenge. It's the challenge isn't all ours. And the ICP and our local authority partners are really keen that we remember that, and so we should. And that's back perhaps even to the point that Simon made, where we can share resources, we should. And that's not always money, but that might be time and people and knowledge. Access to pharmacy and dental services, clearly hugely important to the populations we serve, and that comes through our Integrated Care Partnership from Health and Wellbeing Board chairs, and to some extent your performance review has helped us with that, Amanda. And then this very important issue around local authorities seeing the cost of living impact on carers and people living with chronic illness. I don't know if any of our local authority board members want to comment on that. Yes, Jonathan.
Not particularly that, but a more general issue. I think because of the financial pressures across local government in particular, there's going to be more of a spotlight on those areas where the NHS is perceived not to be picking up the cost of various treatments that local authorities and social care are still picking up. And I think there's going to be an increasing focus on the debate in months to come. So I know we are, that's being parochial, but areas where they, you know, we've maybe picked up the social care cost. At the expense of the
and that's why integration is so important, isn't it? Because we can't let the row about whose job it is get in the way of doing the right thing, can we? And that's why those channels of communication need to be absolutely wide open all the time, because those arguments are a waste of time, aren't they? The best use of our time is to work out how we use the resources we've got to do the right thing for those we serve.
But also on the cost of living crisis, that still is impacting different members of the community. We're doing a lot of work now about where do we give council tax relief and things like that, and that's a shift from probably where we were 2 years ago and who we were supporting. That cohort is changing.
Thanks, Jonathan.
Going into that.
That's really helpful. The clinical professional raised an alert related to the need for outcomes for paediatric asthma to be improved. Do you want to comment there, Nigel?
Yes, please. Thank you. Thank you, Chair. We had a very powerful presentation from Jen Brownbridge, who's the lead nurse for the Children and Young People's Transformation Plan around asthma and asthma outcomes for our populations. And it really centres on the need for accurate diagnosis and continued optimisation of management of asthma for our populations, and especially for our children and young people. And I wanted to bring it here because we have an ambition for the generational change around children and young people anyway. And the other thing in this is the wider determinants of health around asthma and triggers for asthma that will ripple out of the ICB into the ICP around the social determinants of health, housing, triggers for asthma attacks, but also then the fact that people don't get to education because of that as well, because they're not able to get to school. So it was a really, really powerful discussion, and we are looking at some areas that we're going to support with this, which is to try and increase the capacity for diagnosis and diagnostics in the CDCs coming forward.
Right.
We've got to remember that asthma is a clinical diagnosis, but it has to be backed up to get coded accurately on some registers by investigations, and that in itself has some issues. We need to make sure that when children and young people aren't appropriately or in those diagnostic pathways, that they're coded appropriately, so if they do run into problems, that they can be managed appropriately. And then we also need to look at the wider determinants and where we need to go with that into the ICP as well. So I thought it was really important that the board were aware of the issues that are happening. And we've got to remember that asthma is still a killer, and it still kills all ages, but children and young people as well.
Yeah, thank you, Nigel. Thank you. And finally, Stuart, alert relating to audit, but I think that's coming to the next meeting of the board. Is that right?
There's only technical matters to do in terms of reference, so I don't think we need to.
Okay. Thank you. Thank you very much indeed. Anything anyone would like to raise as a result of reading that committee report? And can I just confirm that the board is happy with this way of feeding back from the committees?
Yeah.
Good. Thank you. Okay, let's move on to item 12. This is with you, Karina. This is around board effectiveness. I think there are a few things that we're asked to do as a result of that. It was a good read, wasn't it? And I felt pleased when I read it. I hope you had a little moment of pride in the work of the board. But Karina, can you lead us through this, please?
I can, yes. Thank you, Chair. So it is in two parts, this item. The first part is in relation to the board itself, and then the second part is in relation to the committees and the assurance reports relating to each of those. So I'll start with the board first. And in general, we've followed an effectiveness review process that we've agreed here in terms of a light touch approach. It uses the Healthcare Financial Management Association, so the HFMA Audit Committee Handbook guidance, which helps us to determine if the board has carried out its duties effectively for the year. I know, Chair, you have reviewed all of the papers and satisfied with what was in there, and really appreciate the comments that you've just made. It is just in terms of if there are any further comments from colleagues around the table, but we should recognise as well that the attendance records show that we've had really good levels of attendance at the board. We included the self-assessment in terms of for the board to review, comment on as appropriate. Consider any mitigating actions that will form part of the plan, but then we conclude overall that the outcome of the discussions provide assurance that the board has been operating effectively in 23-24.
Any comments anyone would like to make about that board effectiveness report? Well, it's well done to all of you, so thank you to the board. Karina, moving us on.
Yep, so again, following the same process, we used the HFMA guidance for all of the committees. Each of the committees have had an effectiveness review, but they've also done an annual report, which is available in the supplementary information pack. We have got amendments to make to each of the individual terms of reference. They have been or are still going through some of the boards, some of the committees for approval, and will be brought back to the board, this board for approval in May, so that people can just understand any future things we might need to incorporate before we do that. So it's really just to note the self-assessments, note that each of the committees have done an annual report, and that the committee terms of reference will be brought back as a pack in May for final approval.
Thank you, Karina. Any questions? Jane?
Do these form part of the annual governance?
Yes, they do.
Karina,
Yes.
yeah, I thought they did. So that will, again, that will be a publicly available document as well, won't it? Yeah.
Yeah. Louise?
Yeah, thanks, Karina. And just as a co-chair of Pop Health Board, going through the kind of audit process has been really helpful. I think it's just a moment to stop and reflect and actually think how further on do we push ourselves, and hopefully I think subject to May, get some reasonable assurance on all of this, but it was a really useful process to go through and just to hold the mirror up to ourselves and ask those questions about are we being as effective as we can be.
Thanks, Louise. All of this indicates our developing maturity, doesn't it? Our maturity as a board and our maturity in terms of the governance that surrounds the work of the board. And that's all positive. 2 years ago, we didn't exist. So these are achievements. And I do, again, say thank you. Jane, the workforce breakthrough plan, you've got a paper for us to note.
I do. I've got a paper and a couple of slides that I'm just going to share with you. You've also got on your tables in front of you a booklet that explains our last year's 23-24 programme. Some of you have already had it, so you might not have the booklet in front of you, but the booklets are there, which explains what we've achieved over the previous year. But the most important bit, there's 2 programmes that I just want to share with people, and that's our development of the Breakthrough ICB programme, where we are with that, and Stephen's referenced a little bit of that already, and then the Breakthrough HMY proposed programme for 24-25, which will go to the Workforce Board next week for approval and through to the Leaders Forum at its next meeting in May. So the couple of slides, there is a slide pack that is in your supplementary information, which is a bit more detailed than the couple of slides I'm going to just share. But if I start with Breakthrough HMY, and to remind people that this is very much worked through a distributed leadership model and is worked with partners right across our system, which includes local government and also voluntary sector, as well as Skills for Health and others. And we held our Workforce Summit 2 or 3 weeks ago now, and this is the output of that summit. We've also got the Grant Thornton work, of course, that has recently been working through our system, and there was one particular area of focus in there about workforce and pay reduction. So you will see across the top of here, 6 committees that report into the Workforce Board, and to draw attention to the new one, which is the Pay Bill and Agency Management Committee, and that will pick up the significant pieces of work that are linked to the financial challenges that we face across our system in 24-25. And some of the other work that we had in our 23-24 programme will feed into this. So things like the development of the collaborative bank, for example, will now be picked up through that Pay Bill and Agency Management Committee, as well as the portability work that we've been doing around how staff move around the system. That will also feed into this. You will see that for the 6 committees, we've got chairs for each of those committees from across our system. You can see who those chairs are across the top. And the one other area that isn't actually a committee is our System Inclusion Assembly, which brings together partners right from across our system that focuses on inclusion. And I'm doing a little bit further work this afternoon to talk about where we are with some of our work around that. You will also see that there are other programmes of work, task and finish groups, if you like, that we will work on across the year that aren't set up as proper committees, but are doing really important work for us. That have come out of that work, and then some specialist transformation projects. So if we look at the oral health workforce, for example, that's quite a specialist area of work and is picked up through this work for 24-25. So they're the proposals for 24-25. I don't know if people have any questions on those first before I move into the ICB work.
Stephen.
It's just a presentational point, not for today. I think what would be useful for this forum, and especially in public meetings, is what the outcomes are from all of that.
Yeah.
Those elements, you know. So just as a point of action, really. Thanks.
That'll get picked up, Stephen, through the terms of reference and the work programme, so I can bring those back.
If we can have a regular input here, I think what would be useful is to say, well, what exactly has happened in pay bill reduction, or whichever one of these.
I think it's a very important point about what actually happens in any of our committees and any of our work, actually, so that we're delivery focused, not just commentating on actions that we might be going to take. So yes, thank you, I can do that.
I think when we've talked about productivity, and we know we're going to have some proper measures of productivity in this year ahead, one of them is absolutely our pay bill spend, particularly around agency and locum staff. That will be a critical measure for us of the productivity of our system. So we need absolute transparency here at board around that.
Yeah. The first meeting of the Pay Bill and Agency Management Committee is in a couple of weeks. There's already the team set up around that, so we'll hit the ground running in a couple of weeks' time around that committee.
Thanks, Jane.
I just brief additional point, if I may, that I don't want us to just focus down on that. There's 6 really important dimensions there. I think what would be really helpful is to understand what the outcomes are in each of those areas as we progress through the year, because of the focus we've got on workforce.
Yeah.
You know, because there's the overseas recruitment agenda that we've talked about before, and there are differing views around the board about that, aren't there? So that we've talked about it. So that's what I think the emphasis should be in the meeting here. I know we're setting it up today, but moving forward, that's where I think the emphasis should be.
Yeah, that's fine. I can pick that up. And then the last slide that I was going to show. Now, you've seen this slide before. There's, other than our organisational values across the top of the slide, there are no changes to that. But I just wanted to draw out where we've got to in the development of our ICB Breakthrough programme, because we're in the process of testing our values through the roadshows that Stephen referred to earlier. We had the first roadshow on Monday. That was a really valuable session for feedback from our ICB colleagues around their views on the values. And yesterday with our leaders, we got some teams working on what our leadership charter would look like, and also our behaviours framework. Really important to see those 3 together. If you just look at the values in isolation, or any of those bits in isolation, it doesn't really explain the full scope. We've got our roadshows continuing until mid-May. We do have a board session, though, where we will be doing some work on the values and the charter and the framework when we have our time out at the end of April. So the people here will have an opportunity to be fully involved in that.
Thanks, Jane. Any further comments for Jane? Thank you. Let's move to item 14. And this is the point in our board meeting where we reflect back on our BAF conversation, and we reflect back on the conversation at board, and we ask ourselves, have we got the right risks on our board assurance framework? So given the conversation we've just had, given the things that are on our minds, does the BAF accurately reflect the risks that we've discussed this morning and the things that concern us in terms of our ability to achieve our ambitions? So my question to the board is there anything that's arisen for you during the course of this last 2 hours that makes you think we need to make any changes to the BAF, any additions? I mean, we had an impassioned conversation about mental health, didn't we? Particularly young people's mental health, waiting times. I don't know. Is that the sort of strategic risk that could be on our BAF, should be on our BAF? Amanda, Stuart?
I suppose it comes back to the point when we talked about the BAF, in that I think as we move into next year and we see where we are predicting and what our ambition around those objectives delivery laid out in the operating framework, if as a system we are saying we're not going to achieve for our population those targets we want to for mental health, that might be an area of focus deep dive that we want to get into. I think delivery as a system, given the complexity and the challenge we're going into the year, it's a BAF risk that needs to be there, and it'll be a subset of that.
Okay, thank you, Stuart, and then Teresa.
Mine's connected to the earlier point I made about the performance report, because we have collaborative leads with us there, having their particular view on what we talk about in the BAF, and you've just illustrated it with the one you brought up, would be extremely useful.
Yeah, okay, thank you. Teresa?
Just to say that waiting times and access issues are a fundamental part of the quality consideration. So for me, they're picked up in that, because that's one of the contributing factors to our.
Maybe we should make that more clear. Richard,
just reflecting on your comments around the kind of demographic changes and whether or not that's fully picked up. There'll be strategic objectives for the system to develop services and change models and become more effective and transformative, but do we need to be more explicit about the need to change how we plan for our future services based on those demographic changes? Because we're going to have to start working on that now, I'm sure we already are, for things that are going to come down the track in 5 years' time, 10 years' time.
I'll be honest, I was wondering the exact same point.
Right. Okay.
Maybe we could reflect on that when we've had the development session and the
Yeah. Okay, thank you. Item 15, some items for information. You always receive a good news briefing appended to the board papers. I hope that you've taken time to read those, as well as the things that concern us greatly. As I think a number of you said this morning, there are some absolutely amazing things go on in our geography, and we have to make sure that we stop for long enough to notice that and recognise that. Actually, it says here questions from the public none. I did have some correspondence from a member of the public, and it was an important piece of correspondence which came to me via Councillor Owen and then on to Amanda. Amanda, do you want to just fill us in on that, please?
Yes, so the particular query was in relation to the update that I provided last time around the CDCs and the development of that. And I went through a headline update around the progress of the hub and spoke model, and it was a query around Scarborough around the progress of that site. So as a result of the question, I did confirm that York and Scarborough Trust have purchased the land, contracts have been exchanged, and as part of the that process, they were also developing the site at the same time. And I think I shared with you some photographs of modular buildings on the site, and there is an offer once that's a safe site that there could be a visit for the person that raised the query. So yeah, hopefully that closes that down. And I think as well we said that we would bring a more detailed update report to a future board in terms of the whole CDC programme.
I'd really welcome that. I think that would be great. Yeah. Thank you, Amanda. And Anya.
May I just add, so board colleagues are up to date. I also had a member of the public that had made contact actually through the experience team, and it was off the back of the update that was given in terms of voice of the lived experience in relation to patient transport, and asked if we could think about doing more in communicating the various transport options that were available. So I responded to that member of the public, and of course we will look at how we can improve communication in relation to transport options.
It's a subject very close to my own heart, so absolutely yes. Jonathan.
I think it's just a general reflection. Thanks to the response that Amanda gave, which is spot on, thank you. I think it's also in these sort of political times, you'll find that people find any routes to sort of watching these processes, picking them apart, having a look together. I think that will increase over the next few months rather than decrease.
Yes.
But I think maybe we talk about risk as well generally beforehand. There is a risk, I think, of public perception of where we are in the NHS systems at the moment as well, because the news coming forward is more negative than positive at the moment, so there might be risk around public perceptions to what we're doing and what we're achieving. So I just flag that up as with my small politician hat on. Thank you.
Thanks, Councillor Owen. Jason.
Just to pick on the transport issue. So I think I spoke last time around how the VCSE Collaborative had led a really interesting piece of work around starting to think about what the options were and what currently existed in terms of community transport. So we are literally about to commission the piece of mapping work, which will tell us not only what the commission services are, but what the other community services are. And I think that will probably put us in quite a strong place to be able to be, I suppose, broader out in the information that we kind of share with people. But I think just the note of warning is I think it will raise quite a lot of issues and challenges for us to think about community transport kind of moving forward, not only in terms of access to services, but also some of those preventative wellbeing services that we also, so it's not just about hospitals, it's about going 3 villages down the road to something which is a natter club, which from the mental health point of view is really important, but at the moment we don't resource that, we rely on kind of goodwill. So once that piece of work's kind of finished, we'll bring that back, but there is quite a lot of progress and interest around it, and I think we have responded very positively to challenges from communities around community transport, particularly I think from the East Riding. Jonathan?
Yeah.
Thank you, Jason. Michelle?
Yeah, it's a really interesting point and a really crucial point, because I think it links in to a lot of things what we've been talking about today in relationship to improving excellence and delivering and leading for excellence and sustainability.
Do you maybe need to speak into your microphone, Michelle?
I'm going to take into account the volunteer situation as well, because I think there's a bit we could do in relationship to maximising where the volunteers are around the ICB, if you know what I mean, to maximise the benefits of that. So I just wondered if we were going to link that in.
Jason?
So through the breakthrough programmes, one of our work streams is volunteers at the heart of the system, where we've done that piece of work around understanding what the volunteer offer is across our whole system and around how is our volunteer offer kind of being used. I think, and it's interesting Stephen's point around actually what's the tangibles, because for the volunteering one I think we probably know enough now to be able to say let's think really, really creatively around volunteering. How does that fit to workforce? Actually, how do we start to really better understand what the potential of volunteers are? So being really careful not to tread on toes. So we're using volunteers to fill gaps, but actually they're appropriate roles. But also the amount and quality of volunteering we have in our system. I'm thinking about the health captains that work through and the volunteering offers that happen through HUFT. There is an awful lot of stuff, and at the moment, when we talk about quality, efficiency and productivity, everybody's competing for volunteers. There's no one single approach. If you want to work in 4 different places, you have to go through 4 different DBSs and 4 different bits of training. There is a real lean and mean bit around volunteering, but also recruiting once and well and offering people an option in terms of where do you want to work. And actually there's a really sound platform that I think it's taken us 2 years to unpick it. And that piece of work, I'm really proud to say, has been led through a workforce lens by the voluntary sector. I think we've had significant buy-in from all of our providers around their current volunteer pools. So we are looking at that. We're probably just not shouting about it enough.
Thank you. Well, perhaps you should. Thanks, Jason. We're into any other business now. There are just a couple of things I want to say. One is to absolutely draw your attention to this document, which is the 23-24 review. We haven't done this before. There's a danger, isn't there, for an organisation like ours that we're seen as just another layer of bureaucracy, and that there's challenge around where does an organisation like ours add value, and actually does what we do make any difference at all? Now, it's really, really important that we do, and we've sought to capture that in this document. That feels really important to me. I'm keen that we share this document as widely as we possibly can, and that we take pride in what we've achieved in the course of the year before. So let me just commend this document to you. And my plan is to leave it lying around at home, because I don't know what your family and friends think you do when you're doing ICB work, but this would be probably most helpful guide for them. So that's the first thing. The second thing is I want to say what a great board pack I think this was. The Neds and I have just an hour together before the board, and we all felt that the way this board pack was put together, the way it was organised, made it very accessible, easier to read. Yeah, we just liked this board pack. So again, in the spirit of credit, I thought this was a good board pack, and I hope others did too. So we're going to keep working at that to make sure that our board pack enables us to have the very best board meetings that we can. This closes our public meeting. We'll meet again on Wednesday, the 8th of May at 9:30. That meeting will also be in public, and again, you'll be able to get the details on our website. So as we close the meeting, we exclude the public and we exclude the press from the next part of our agenda. Thank you.
Thank you.
Good morning.